first of all, thank you very much for inviting me. I'm very impressed with your consortium, and in my broken German, I was already quite interested with what I heard. I'm sorry I missed the earlier part of the talk. I'm going to give I hope, relatively brief 20-minute presentation, lead time for questions. And frankly, Tomas, if you can check the chat line, so if there's questions that people want to interrupt me with, feel free to interrupt me. All right, let's see if we can get the show under the road, so, as the Americans say. Okay, let's see. Okay, and let's see. Share screen, desktop one. So tell me if you can see a nice white screen. Do you see a nice white screen?
Yes.
Well, just white.
Your top bar with the Sunyas.
Ah, good. Oh no, I think you're seeing my presenter view. Is that true?
Now I'm seeing the first, what happened, what seems to be the first slide.
Yeah, we can see the slides,
but
what
we learned about
a little bit is cut off at the top, but otherwise I think.
Wait, let me, I know that people hate when I do that, but let me try, let me try one more attack here. So, share screen. Let's see, maybe what happens if I do PowerPoint? How about that? Is that better? Is that better? Can you see it?
Same as before.
Yeah, we can see it. It's fine.
It is fine. Right. It is as before.
Fine. All right. Well, I'll start talking. So you asked me to talk about what we learned about the failures of data science in the COVID-19 pandemic from the 4CE international collaboration. So this is it's a quick story about what happened during the pandemic that's relevant to some of the tools and players that you are well aware of. And so I am inspired by a quote from Schopenhauer. Es sind die Feinheiten, die den Unterschied ausmachen, dass uns das Schicksal die Hand gibt und wir spielen die Karten. And in that respect, I think we need to take this very seriously because it's some of these fine points that were totally missed, and as a result, major errors made during the COVID pandemic. So, like many others, when the pandemic started and I started getting, as everybody else, quite alarmed in early February, I started looking at all these news stories, and I was talking to colleagues in Italy and in China, and it was very hard to figure out what was going on. For example, we knew that the ACE receptor was being bound, and we also knew that lots of our patients were treated with medications that treat various parts of the angiotensin aldosterone system. Would these medications make it worse or better for these patients? Should we switch them off, these medications, or not? It was very hard to know. We heard some stories about there being coagulopathy. Should we anticoagulate these patients? Being a cardiomyopathy, should we be taking more care of heart conditions in these patients? It was really hard to know. And as I was watching this, I was well aware that we and a number of colleagues around the world, including yourselves, had built an infrastructure, the I2B Transmart system, that would allow us to bring together all the data from genomics, from clinical data, EHR data, and from textual data from a variety of sources. And was this being done? And I was quite aware that this was an international toolkit that many of you were involved with, because in our I2B2 academic users group, you had joined us in many meetings to discuss how you were using technology locally, how we were using technology. And so at the beginning of February, I was waiting for large governmental organizations to put together the infrastructure to be able to answer some of the questions I just mentioned to you early on. And then as I was listening carefully, my gray hairs and the knowledge that goes with them made it clear to me that although there were many large multi-$100 million or euro efforts being engaged in, the approach was so slow and so top heavy that at least in the United States, we would only have an integrated view at best of what was going on, at best 6 months from then. And as I grew increasingly alarmed about the fact that there was a absence of real on-the-ground knowledge at a systematic level, by the time the beginning of March occurred, I reached out by email to some of my colleagues nationally here in the United States and internationally, including some of you, and said, guys, ladies, we've done this before. Can we do this now? So we engaged in a very rapid sprint where initially we started this consortium, and it started within 1 week out of the email with what at the time it seemed interesting and now it seems boring and horrendous, namely Zoom conference calls. But we started doing it every Friday where we were meeting, not to discuss things, but to discuss our results. And within the first 4 weeks of our consortium, where we had 5 countries, now it's 9 countries, where we had over 100 hospitals, where now we have 350 hospitals. But just with those over 100 hospitals and with those sites across Europe, the United States, and one in Asia, we were able in 4 weeks to actually get a pretty good idea of what these patients looked like in the first week of their admission to hospitals across the world. And we published it within the medRxiv within those first 4 weeks. Sadly, and that's another commentary of another type of failure, we were very pleased to get this published in Nature Digital Medicine. But the way modern publishing works, even though the medRxiv piece was out in 4 weeks, the Nature Digital Medicine piece came out in July, so at least 4 months later. And so what I'm talking to you about is some of the learnings that we've had in that context. And so while this was happening, again, throughout Europe and throughout the United States, major efforts were being made, like the N3C consortium, and hundreds of millions of dollars were being expended. But what we were not hearing was, again, what we saw and what we published in this medRxiv paper, namely that from the beginning, from the very beginning, D-dimer, a measure of coagulopathy, was off the charts, numbers that we had never seen. And you didn't have to wait for months. This is days. And this is, by the way, across all these international and national sites. We saw a crazy rise, and this is already on day 1, crazy high D-dimer, nothing to discuss about, it's there. We saw high C-reactive proteins and a beginning of the nephropathy. Of course, the high white blood count, and I'm not showing here, but we also saw the neutropenia. And if this had been widely followed, and if this methodology had been taken, for instance, the anticoagulation could have been started within a week because it was actually knowable across thousands of patients. a trial bigger than any modern trial, but we weren't looking at it. And what was our methodology? Our methodology was literally the following. Each one of these I2B2 Transmart and OMOP sites, we gave them a script to run, and then they had to modify it locally. And they only shared back with us, not the detailed row level data. They shared with us the aggregate data. Why did we do that? It's of course better to have row level data, but we knew a number of things. A, getting the IRB protocols across institutions in the United States, and certainly across countries in Europe, would take us longer than all the technical challenges. So we were going to just cut through that and deal with the fact that we were only going to report back from each site the aggregate data, and therefore have to use meta-analytic approaches. But even with that coarse meta-analytic approach, we could see the signs that we showed you there. And we also could show, interestingly, that despite all the news stories about how patients were different, maybe in the Lombardy region in Italy versus Germany versus United States, the way these labs obtained from the electronic health records through these tools, I2B2 Transmart, OMOP, the labs on presentation across countries were very, very similar. In fact, most of the variation was not between countries, it was within countries. What kind of hospital you showed up at was much more relevant than which country you were in. And as a result, because this actually succeeded, this ad hoc consortium firmed up into something that now covers 9 countries, 350 hospitals. We continue to meet on a weekly basis, at least, but different spin-off groups, kidney injury, neurological, coagulopathy groups have other meetings throughout the week. And that's because this is effective. And not only that, we were seeing in real time the fact that different codes, different ICD codes, different loin codes were being used differently in different institutions, something that would have been we would be unaware of if we had just matched on standard vocabularies. We actually had to look at the data and see, oh yes, these people are using an ultra high sensitivity troponin test, and these are just doing a classical troponin test. These are niceties that I referred to in my Schopenhauer quote, niceties, subtleties that are totally missed when you just do the aggregation and you don't have the data experts and the domain experts as part of that integration process. And not understanding the way hospitals work leads to truly awkward and dangerous outcomes. Shown here is a news story about the Epic electronic health record system and how they had a machine learning or AI program that could predict deterioration that seemed particularly relevant around March and April of 2020, when we were beginning to think that we might have to, as Italy had to do, triage for ventilator and other resources and predict who's going to deteriorate first, so perhaps determine who gets preferential treatment. But fortunately, it never got there because this machine learning program, which was trained on a few hospitals, very, very, very predictably, when it was applied to other hospitals, other Epic hospitals, the performance was much different because these are different hospitals with different populations treating patients differently. Not only that, the same hospitals where this was trained up had to switch off this machine learning program because 6 months later, COVID was not the same disease as it was 6 months earlier. Why? Maybe the virus had changed, but also the practices had changed. How we ventilated patients, the use of glucocorticoids. And so again, using the same algorithm in the same hospital 6 months later had disastrous results. And by the way, I just published with colleagues in the New England Journal of Medicine an article just yesterday about data set shift and how this will upend many machine learning efforts if we don't understand the data, as we do in the 4CE consortium. Also, we were very, very upset when we thought we were being scooped by this group that had published in the Lancet and the New England Journal of Medicine about results across literally hundreds of hospitals in many more countries. And we were looking at the data and said, how could they have scooped us? It's so hard to actually look at this data. Even if you have a mapping table, you need to really look at the data to debug it. And we started thinking that there was a problem. And we informed actually at least one set of editors. And sure enough, both papers had to be withdrawn because it was too good to be true. The data didn't exist. And two very high profile journals published these papers because they seemed to say something that everybody wanted to agree with. But the point is, neither the journal editors and neither the reviewers knew enough about the way electronic health records work, the way real world data works, in order to be able to understand that this could not possibly be real. But if you looked at the submission, it could not be possibly real. For that reason, we published recently in the Journal of Medical Internet Research a article about how to what every reader should know about studies using electronic health record data, but may be afraid to ask, where we go through all the aspects of EHR-driven data and what someone like you, people who are involved in the I2B2 Transmart system, would know, like understanding what clinical variables can support, understanding how the phenotypes are generated, knowing what phenotypes can be reasonably generated from natural language processing and which cannot, understanding the biases that come from manual coding of the data, and so on. And there's much more there, but in the interest of time, I'll move on. We also showed that we don't have to wait for a lot of manual curation, that if we just use expert knowledge about what constitutes, for example, a severe patient, the fact that they're in the ICU, the fact that they have a low oxygen saturation, the fact that they're being given anesthetics or cardiac anatropes, allowed us to identify just automatically with high sensitivity and specificity those patients who are very sick, who are severe COVID patients versus those who are not. And it showed in some of these diagrams, that are much more in the paper, that we could actually find distinct courses of these patients who presented early, severe versus non-severe, and we could show the underlying differences. But in order to do that, you had to understand not only the data, not only the medicine, but also the process of healthcare, so that you could actually use the right variables to do this. And the interesting good news is that NIH finally understood this, and now there's this big $100 million system that is being built for the post-acute surveillance of COVID. And even though there was $100 million invested in this other system that I told you about, they were very clear. They wanted Paul Aviak's cloud-based environment in the AWS to be used because of its data security, and to use the I2B2 system for gathering the national experience in COVID, so we can run a bunch of studies from there. And so these are using all the tools that you and your consortium are well aware of. I want to give as a counterexample of failure, this example of success. So our colleagues in Israel have really used their HMOs as effective tools to both survey their population in real time, but also to implement policy. And here is a paper that was published back in February of this year about the efficacy of the Pfizer vaccine. And it was the first large real world data showing the effectiveness of this vaccine, and it appeared in the New England Journal. And the reason that they could do it is because the first two authors, these two authors, Noah Dagan and Noam Barda, who, by the way, are postdocs in my department this year, they work directly in that healthcare system and have helped build and mine the infrastructure. They understood the data, not only medically, but they understood the subtleties from the way these data were extracted and put into the EHR and then into the analytic database. So in summary, data sources matter, and we have to understand which ones we're using and what their pros and cons are. And I could go much longer about this, believe me, I have in other venues, but I want to be able to entertain some questions. And the difference between using data and domain experts as explicitly part of the analytic phase, as opposed to first doing this distant and decentralized aggregation where the connection to the original data is lost and where you don't understand how the data are generated. This is a clear and present danger and will set us up. If we don't understand that lesson, then we're going to take advantage of the Schopenhauer quote. We're not going to play our cards correctly. And so I'm going to argue that the kind of expertise that I believe your consortium, that I'm glad to be a scientific advisor on, is trying to develop this multidisciplinary approach. It's not a luxury. It's not nice to have. It's essential. Otherwise, we will not be using the data effectively today or in any other future public health threats. And with that, I invite you to visit our website at the Department of Biomedical Informatics, and I'm glad to take any questions in our remaining 6 minutes.
Yeah, thank you very much, Zach, for this great presentation, giving us an overview of the 4CE initiatives and what you were able to implement. Yeah, would be very happy to take questions from the audience as well as in the chat.
And I don't mind. I don't mind aggressive ones. I don't mind questions that say, "What the hell? What are you saying?"
No, not an aggressive question from my side. I'm Martin Böker from Munich now. I was very happy to participate in this project over the last year, and we were very proud to provide data for these results. And I have two questions. One is to learn as an European, I think we can learn a lot of these pragmatic approaches. What would you say is the most important single factor to bring such a project up and sustain it? This is the first one. The second one is a little bit more skeptic. As you said, the health service systems are very diverse, and you cannot control for data quality. How can we deal with this problem?
So those are good questions. And in fact, if those are the only questions, I'd be happy because those are essential questions. So I have to share with you, I come from a not quite European country. I grew up my first 17 years. I was born in Geneva, Switzerland, and I still have my Swiss passport, by the way. And I realized that because of our unique characteristics, we're not quite a member of the European Union, which might be a good thing, actually. Growing up in Geneva, I was surrounded by all these organizations, the ITU, the WHO, United Nations, the International Labor Organizations, all had these committees coming together in very nice places with very nice dinners, meeting endlessly about things. And that struck me as exactly the wrong, and I developed early cynicism about that because I grew up there. And the short answer is, it became clear to me that the American way, and it's part of the reason why I left, even though my parents were from Europe, this American accent is a weird aberration. But the one reason I came to America was that I knew there was going to be opportunity to be a little bit anti-hierarchical. And I want to point out that the major successful trial in COVID in Europe that affected all of us was the discovery trial in the United Kingdom, where they discovered the effect of dexamethasone. And if you look in detail at what they did, they admit that they blew away all their standard bureaucratic requirements for running studies. They simplified. They, if the IRB wanted something detailed, they said, forget about you. They manually some data, they forgot about some rules. And as a result, they gave this huge present to the world, which is the most effective drug that we've found so far, despite everything, to treat COVID. And similarly, what I want you to really hear me is that not only did I sort of say, I'm not going to wait for some big man to put together the data, and I called out to you, my colleagues, to work with us. But I recognized that the data was going to be very uneven, because that's the real world, and that we were going to need the help of all our colleagues to help us watch out for the holes and blocks and problems with the data, because everybody locally understands their data the best. And though it cost us a lot of time, sweat, and conference calls, as a result, I am much more confident than most people are about their studies, about how durable and reproducible our results are. So I think the short answer is, although it seems like it's only true in emergency, it's still always true in peacetime, because we need to move medicine fast. And although we seem that we had to move medicine fast for COVID, there are a bunch of people dying every day due to our mismanagement or misapplication of current technologies and drugs for cancer, missed opportunities. And we've documented this in the I2B2 system many, many times. So I think what we should learn is, if we really care about patients, if we're not here just to be academics sitting around conferences and congratulating ourselves, I think that if the goal of the game is to help patients, yes, we can be good citizens and participate in all those meetings and so on. But what we really have to do is to understand that those of us who are generating the data and curating the data have to be part of those who are asking the right questions and helping those questions get answered. So it's not waiting for some mountain of a genius of a system to do it. It's acting locally and bringing together your colleagues to move forward. So Andreas says, what do you say? Is better to bring the, I think that, yes. So Andreas writes a great question. Would you say it's generally better to bring the question to the data instead of collecting the data centrally? So I think it's a matter of time. Over time, as we start analyzing data, there's a nice feedback loop, but it's a slow feedback loop, which is the centralized analyses start affecting local practice. I can tell you in early I2B2, we found out, for example, that it's a longer story, but a lot of the diagnoses were incorrect. And because of that, because of our natural language processing, we figured it out. And so this caused a change in the way diagnoses were coded. So I think ultimately the centralized systems, the centralized data banks are important, but you have to be very close to the data initially to make sure you have an ongoing feedback loop. Otherwise, it's too easy to say, we paid for the centralization, done, let's forget about the painful and labor-intensive local work, which actually has to continue. And we are seeing that. And so the reality is we do need central databases, but the data collection systems are not mature enough that we can forego learning from what we're seeing locally relative to the questions. And then we can continually improve the centralized data sources so that eventually they will be much more comparable. So yes, I guess I am in agreement with your first statement. And by the way, just to be clear, we're playing it both ways. We're centralizing as well as continuing to the localized analytics, because we do need to have a centralized view. But I can tell you for a fact that most of the questions that we've tried to answer, when we have done that, going back to the local perspective, it's so obvious that the questions are unanswerable.
Yeah, thank you very much.
So I think I've run out of time, guys. And I hope in the coming years we get to meet in person. Maybe we can even return to my hometown where I still have an apartment, and we can have some nice beer and wine overlooking the Jura or the Alps, and actually discuss how much progress we've made since then. So thank you very much for inviting me, and enjoy the rest of your meeting.